Hi, everyone. My name is Paul Hemmer. I'm the Vice Chair for Education in the Department of Medicine at the Uniformed Services University.
Bill Kelly, Medicine Clerkship Director.
Hi, I'm David Lindholm. I'm the Deputy Clerkship Director.
And we'd like to welcome you to our session.
And that session is the relevant rhythm of rhyme. And we have no disclosures. Any conflicts of interest have been resolved. And while the three of us work for the federal government, these opinions are our own and don't necessarily reflect those of the federal government. Now, the goals overall are to talk about how synthetic frameworks like RIME can help you and help your faculty as you roll out entrustable professional activities. Now, I'm going to talk about different types of frameworks. Dr. Lindholm is then going to come over and review RIME, and then Dr. Hemmer will take us home with the connection to EPAs. Now, we have a couple assumptions up front. First is that with any model you use, there is direct observation. Work-based place assessments, you have to observe behaviors to assess. And then hopefully we'll talk about this during our live Q&A session, but conversation is so important. You really have to talk to your faculty to get a sense of learner performance. It's not about filling out a form. Now, what's a framework? It can be known as a scaffolding, something that you build other things upon. In medical education, it's really a concept, an idea that hopefully we can all get behind to evaluate our trainees. Now, there's primary effects. Certainly a framework, or the framework you choose, is going to guide your faculty in their assessments. It's going to let your learners know what's expected of them, and it helps you blueprint your clerkship or course so you can meet those goals and assess those things. Now, there's also secondary effects, not really side effects, but other things to consider. One is consistency. You have to apply your framework consistently or it's not fair and you lose any kind of reliability in your assessment decisions. And then the more complicated your framework is, the harder it is to remember for your faculty, the harder it is to track, and it's difficult to get buy-in and use it as intended. Now, there's three major types of frameworks. I'm going to start with the analytic approach. That kind of deconstructs things. You take what a good doctor is and you break it down into different components. Here you have the very familiar 6 core competencies back from 1999. But those then get broken down into subcomponents and eventually milestones, and the list gets very long. Analytical is great. It's discrete measurements, but that list can be overwhelming. And Amy Guide number 78 and some other handouts have a great review of this. We'll get to you later. Developmental model, it's pretty intuitive. You go from beginner to competent to expert. And in our model, that novice is the medical student or the starting trainee. And then in GME, as a resident appears to graduate, they should be competent and learn proficiency and efficiency. And then obviously we're supposed to be the expert or the master that judges these things. The advantage of that is it goes on for, can go on for years, but you risk normative grading, grading on a curve and not individual traditional standards. So synthetic approach does the opposite sort of the analytical method where you're building something from its component parts. Here's the CanMeds model from 2005, and it takes several of these things to successfully do an entrustable professional activity or EPA. At the bottom, RIME, the student's role, which demonstrates expertise, skills, knowledge, attitudes, can be seen in one of those EPA events. So now these synthetic frameworks, you're putting everything back together. Obviously, all the components of knowledge, skills, and attitudes are required to work together to pull it off. There's a developmental component because you're starting from, reporter, moving towards manager. And for complex tasks that you're observing, like patient care, it can be very helpful because you're looking at sort of a conclusion or total performance. And there needs to be some authenticity, and your learner has to be able to demonstrate these things kind of in a real setting without a lot of cues to show that they can synthesize or do it. Also importantly, you don't have to stick with tradition or use the latest analytic latest framework. These aren't competing with each other. You don't have to be on a team. They're all complementary. Starts with observation in the clinical setting. That's a very synthetic framework model. But then you have to revert to analytic models to figure out where did they fall short, what can they do better to reach that next step. And then finally, that is what feedback is all about for your demonstrating your values and then doing counseling. So with that, we're going to switch to
This is a message from our sponsor, fairness. In order to be fair to students, in order to be fair to faculty, you can't overburden them with needless medical jargon. Remember the motto of internal medicine: embrace complexity, act with simplicity. Remember, the important thing is to be fair. It's hard to be fair without consistency. It's hard to be consistent without some kind of internal construct alignment in the head of your teachers. RIME is the answer. Think about it. Embrace complexity, act with simplicity.
Well, sorry about that interruption. Okay, let's next go to Dr. Lindholm looking at the synthetic framework, RIME.
Thanks. So RIME is one of these synthetic approaches to evaluation where you take the synthesis of knowledge, skills, and attitudes and classify the learner along a spectrum from reporter to interpreter to manager educator. This was first described in the literature by Dr. Pangaro from USIS in academic medicine in 1999, and RIME has been used at USIS for quite a number of years. At the fundamental level, the reporters take the day-to-day professional responsibility and ownership for their patient. They can really answer those what questions, and then they have the basic knowledge of what to look for, and they have the bedside skill to accurately and completely gather data and clearly communicate what they've gathered in an honest and complete way. Not only do they need some degree of expertise or knowledge, but they also demonstrate duty to the profession. These colors that are going to be coming up really map the skills of the reporter, or the aspects of a reporter, to knowledge, skills, and attitude. So yellow here for knowledge, the skills coming in blue, and then attitudes coming in green. And as you can see from the distribution of the colors, much of reporting is really about attitude and professional demeanor. The interpreter then builds on those foundations of the reporter and continues having all of those attributes, but now starts to tackle the why question, and now tackles the why question. They're able to prioritize problems. They're able to break them down for analysis. They're able to offer up differential diagnoses, and they're able to synthesize the case clearly. At the level of the MS3, the key is not necessarily to being right, though that's always nice, but to have reasonable prioritization, reasonable differentials, and be able to express their clinical reasoning. There's a growing independence and confidence as they develop greater depth of knowledge. And this student will also explain their reasoning to their attending in presentations or in their notes spontaneously or even with prompting. And as the educator, you can ask these students to demonstrate their clinical reasoning and explain that why. The manager is doing all of this knowledge, skills, and attitudes that were expressed as a reporter and as an interpreter, and they're taking it to the next step and answering really the how questions. So they're taking all of the clinical information and understanding of the disease process, and then they're able to apply it to their patient to determine the next steps in care. They know when to take action, and they can tailor the action to their patients. They have the maturity and understanding of the evidence that allows them to negotiate with their patients and with their teams in order to develop plans for this particular patient at this particular time. This does require some degree of education of patients, and thus the manager skill is really closely linked to the next level of educator. And these students are really advancing in their expertise. They can identify questions on their own. They have the drive for self-directed learning, to look into the evidence deeply, and then to critically assess the evidence and apply it to their cases. And they're sharing their knowledge and teaching it to others. So they're really starting to become leaders in the care of their patients. RIME works because it's built on a premise of fairness, and it really mirrors the rhythm of patient care. Students and faculty both have to buy into RIME. Students need to see that the model in which they're being evaluated is not arbitrary, but that it's fair and that it's credible, because it really mirrors their development into physicians who can advance patient care as managers and educators. And faculty have to buy into it as well, in seeing that it's simple, that it's easily remembered, and it's an employable framework. And once you have that buy-in, you can start to build in additional detail, as we'll see with the EPAs in the next section. So I'll turn it over for further discussion about EPAs.
Thanks. The transition now, I'm going to talk a little bit about EPAs, and very briefly. It's a crash course in what has been around for about 15 years and something that many of you are probably using or are familiar with. So EPAs grew out of a recognition that the decision about entrustment of residents, this began at GME, is really a synthetic decision. And it was focused around that daily patient care is the core activity of becoming a physician. It's really the core even of the ACGME framework. And it holds that competence is an attribute, it's not an activity, that most of the activities that we engage in actually require us to bring together several competencies, and that competencies are applied across activities. The whole idea is that all of these things, the activities that we engage in, are synthetic. They bring things together in order to accomplish them. So by their original definition, they form the critical part of our professional work that can be identified as a unit and then be entrusted to a trainee once they've demonstrated sufficient competence. But the key is that they're critical activities. They're essential. They're at the core of what we do. And the goal is that they have to be assessed and approved during training. And if you can identify the core ones, you can compile EPAs together to define the critical elements of a profession. I think most of you are probably familiar with the core EPAs for entering residency, a project sponsored by the AAMC that's ongoing. Based on a prior publication that we've had, what we've done is reorganize this, that the EPAs themselves, this list of activities, actually fits very well in a RIME framework. So for example, gathering a history and performing a physical examination is predominantly around reporting. If you go into the manager column, initiate urgent care, to actually begin the provision of care, that's what a manager does. And it actually depends on the step before, recognizing a patient who requires urgent care. So we've split those into two, because recognizing a patient who requires urgent care is something that an interpreter should be able to do. But to initiate care is at the manager level. And from our academic medicine last page, what we did is we graphed this out. And this is, again, theoretically, but when you might introduce reporting, interpreting, managing, educating before students begin the clerkship. And at different levels, you'll be able to trust what a student can do. So in other words, for a student to leave the pre-clerkship and begin the clerkship, they should be able to function at a fairly high level of a reporter when we're checking key findings. But in terms of managing, we'd probably expect that a student could do that alongside of us and not be able to do that independently. So why bother with all of this? Why bother thinking about RIME and thinking about EPAs? Well, as the title of our workshop showed, there's a certain rhythm of RIME that's familiar to all of us. We often think about SOAP, the story somebody tells, the observations that we make, their assessment and plan. This is reporting, this is interpreting, this is managing and educating. It's a rhythm of observation, reflection, action. It's a rhythm that we're used to. It's a rhythm that makes sense for us. And it's a way that we can embrace complexity but act with simplicity. RIME just makes sense. Progress is evident and development is inherent in the model. It synthesizes knowledge, skills, and attitude. All are essential at every level in order to be able to succeed. And the fact that it's simple without being simplistic leads to acceptance. Because people get this and they recognize it right away, you get towards acceptability of a framework. But the other thing it does is it helps put the list of EPAs into a context. In other words, when you're talking about the role of a reporter, you can convey to your teachers, these are the critical elements of what it means to be a reporter. So in conclusion, synthetic models, I think we would all agree, just make sense to trainees and to our faculty. We've very briefly demonstrated how EPAs can be readily mapped into RIME. RIME can provide options then for gathering meaningful, actionable information that inform the EPAs. But regardless, any framework that's part of a larger program of assessment, whether it's RIME, whether it's the list of EPAs, we also believe really requires conversation and resources to be devoted. And at this time, we get to go live and have a conversation with you.